Is your body being a nudge and you would like to nudge it in a different direction? Today we're going to talk about that. So a nudge is, well, a nudge is pestering, complaining, constantly urging, kind of seen in a negative way. That's what a nudge is. This may be an Urban Dictionary term, but it's a nudge. Nudge is what we're going to talk about, because if we set the foundation, the platform of how our body can heal, how these systems can reactivate and repair, well, now there's some really cool things that we can be doing in the field of orthopedic and pain medicine, what I specialize in my practice as regenerative medicine, where we can use tools and treatments that actually nudge the body forward in its ability to heal. But to understand how they work, we have to understand first how the body, your body, heals. So if we have an injury to the body, we incite some damage, we roll or we stumble off a curb, we roll our ankle. In the process of doing so, there's some ligament structures that hold the bones together to create stability in your ankle, and you strain them. If you have a high-grade sprain of your ankle, you can tear those ligaments completely. So we look at these variations of injury. So first we got to understand the type of injury that you're dealing with. Is it a grade 1, 2, 3, where we've totally torn this ligament? Or looking at, say, cartilage in the knee, is it grade 1, 2, 3, 4, which would be like bone on bone at the end? And where and what combination of injuries do we have? So if we're looking at a knee joint, an arthritic knee joint, it's not just the cartilage that's the problem. The ligaments, the tendons that support the knee are also the problem, because if the cartilage thickness used to be like this and it wears out over time, the ligaments become slack and the tendons that support the knee have to do more demand to try to stabilize now. And those tendons and those attachments start to strain around the knee. The ligaments can actually tear, buckle, get loose. We can give way and instability in the knee because of that. But yes, we have cartilage inside the knee, and it's just like having a loose lug nut or two on a wheel in your car, that there's going to be more vibration, more friction, and more wear and tear over time. And you'll wear a pattern maybe in the tread of that tire, just like people wear a pattern in their knee by wearing out one compartment versus another, depending on the mechanics of their body and what's going on with those supportive ligaments, tendons, other tissues. So very important to understand when we're looking to do a treatment like this, what truly is the injury? Because there's plenty of folks out there in the space that they'll just be hyper-focused on the cartilage. They'll just, inject some things inside the knee, like the old school steroid, injecting in there to suppress inflammation. But we know steroids can degenerate the knee faster if we put it in there often. So it's certainly not a tool that I like to use for people, very sparingly in very small doses. But if we understand the scope of the injury, and what happens in an injury is when we tear tissue, what happens is we disrupt some of the blood vessels, we break capillaries, they release cells from the bloodstream, things called platelets. Inside platelets, they have growth factors. Those growth factors are these chemical signals that will start talking to other cells in the body, basically recruiting a force of cells to come there, clean up the damage, stimulate repair, and over time remodel and strengthen it. But in the middle act of this, before we can actually strengthen and heal the tissue, there's a fair amount of inflammation. And this is where people hurt. This is where they get swelling in the tissue. They may be active and their knee swells up. They may feel more stiff around the joint. So there's other symptoms there that are telling us there's injury and damage still in that tissue, and it's creating this inflammation. So we talked about ways that we can modify inflammation and use some things that are reparative. If we're talking about orthopedic problems like cartilage, ligament, tendon injuries. But ultimately, the body's got to work through a process of inflammation as a stepping stone to actually heal. So this is such a key point, and one that most patients, when I meet them for the first time, have never heard and don't realize that inflammation is actually necessary if we want to go up to the next step, which is healing. So in the early process, that first 3, 5, 7, out to 2 weeks, we have a period of inflammation, right? That's the inflammatory phase of healing from an injury. And here's what happens if we gum up the works and we block this. we rob the body's ability to go through this sequence, right, of cellular activity that brings it up here to be able to heal. So this is where things can go awry when, say, a patient reaches for an anti-inflammatory medication because they hurt, they're inflamed, they're swelling, and maybe they saw commercials about just taking ibuprofen so you can keep going through the pain, or whatever it might be, or maybe they're prescribed something. Maybe you were prescribed something by a primary care doc who just wanted to help you with your inflammation. On the surface, there's nothing wrong with that. In fact, that's what I was trained to do in all of my training originally, through non-surgical orthopedic training and through a pain fellowship and through a sports medicine fellowship. It was, well, if your body's inflamed, the first thing you want to do is get on top of that and really suppress things down. But we can see now in regenerative medicine why that's going to impair the process behind me, and it's going to limit the body's systems, right? These cellular systems that are working for you to actually repair the injury. So if we're always on those medications, if we're chronically taking those to help with inflammation, and we're talking about the body's ability to turn over cells, right, to repair the damage or recruit other cells, and we're turning off some of the very signals that are signaling our cells to come there and repair the damage, how effectively are we going to repair the damage? Not that effectively. Will it control symptoms or somebody feel better? Yes, but the underlying pathway or the underlying damage, if it never heals, it's going to start tipping then on the slope to degeneration. Okay, so over time, there's this slow degeneration of that tissue that was injured because it never properly healed in the first place. And then every day, every week, every month, we keep taking these other types of medications. We limit the body's ability to turn these cells over and repair more effectively. So that is the essence of regenerative medicine. So if we get into what we actually can use in regenerative medicine as treatments and put that against conventional treatment. So again, conventional treatment would be, man, if you really hurt and we want to move into the intervention space to do something to the body, well, we blast a bunch of cortisone in there. What's the problem with cortisone? Cortisone, much like cortisol in the body, so cortisol is a stress hormone. So it's kind of that fight or flight hormone. When we get really revved up, we'll kick out some cortisol. And as we learned about, when we're in that sympathetic driving state where there's a lot of cortisol, that's going to be really damaging for the body. That's not the state the body needs to be in to heal. That parasympathetic state of the body, when it's calm, chill, zen-like, like that is when the body can repair. That's when we can turn the wheels on regeneration and repair. So if our body's in a sympathetic state, overdriving cortisol, poorly nourished with the wrong nutrition, not enough sleep, all those things are going to stack against the body's ability to heal. But if we can shift out of that state, get a body into the parasympathetic state, and get the nutrition on board that it needs, we can supplement the right way to help control and modulate some of the inflammation, but not block it. Okay, now we can shift the body over into this state where we can heal, because cortisone, much like that cortisol that's driving that kind of chaos and that damage in the body, will do the same thing when injected in one's joint or tissue. There's very good studies that are published years ago, 5-10 years ago, that show the damaging effects of corticosteroid or cortisone injections on cartilage. It is actually chondrotoxic. What does that mean? Chondro is cartilage, toxic. We know what toxic means. Kills you. So if we put enough cortisone in the knee or any other structure, ligament, tendon, it breaks that tissue down. And it's a very low dose. We're talking on the magnitude of 5 milligrams. That may be beneficial, just like your body when it's under that immediate stress state where you got to fight or flight a little bit, you pump out a little bit of cortisol, your body puffs that out a little bit for you to help get over this initial injury, but it doesn't keep cranking it out, right? It's just like a puff and then it's gone. So the beneficial doses of cortisone may be on the magnitude of 5 to 8 milligrams or less, is what the studies say. The problem is most people, when they've had an injection, what I was trained to do in my former practice before I switched to regenerative medicine approaches, we're putting doses of 40 to 80 milligrams into people at a time. And we would do this repeatedly, because somebody would, have the ongoing pain because it doesn't last forever. It wears off 6 weeks later, 8 weeks later. So we throw cortisone in there again, and now we just damage more tissue. Okay, we impair the body's ability to heal even more. So again, less than 5 milligrams may be beneficial. And I do use that very selectively for diagnostic purposes or to help people when they're in a really bad spot and the knees inflame, chronically, so we can figure out what's going on to move to a regenerative treatment. But we're talking 5 milligrams, not 40 to 80. Okay, so we're talking 8 to 16 times the dose that could be toxic, and we're putting it in there over and over and over. So this is why I use it very sparingly. This is why it's not a primary tool in my tool bag any longer, because I have all these tools. So the tools that I've learned in regenerative medicine, the final nudge that we can give the body that's being a nudge to you, started way back in the 1950s with the discovery of something called prolotherapy. And prolotherapy is, they discovered if they injected a concentrated sugar solution, as we've learned, sugar is inflammatory. But if we very targeted around a joint and injected some dextrose at a certain concentration, it would stimulate a little injury with the injury at the needle mechanism itself. But it would also, because of the difference in the concentration, it would injure some of the cells, okay, and mimic an injury as if you stepped off that curb, rolled your ankle, strained the ligament again. So if we injected all along that ligament, we would create some inflammation. And through that inflammation, if we walked it forward through this cycle and allowed the body to cycle through that for 4 to 6 weeks, we would stimulate a measure of healing. And then based on how well the patient felt, we would do another treatment, and keep walking the body through those cycles every 4 to 6 weeks. This is roughly what it takes approximately for the body to work through a healing cycle. And that's why when you hear injury reports, oftentimes they say the player will be out 4 to 6 weeks with this minor injury. Now, if it's a more major injury or a chronic injury, something that's been there for many, many, many years, it most likely will require more treatment. It's not going to be a one and done or a couple and done type of treatment when we're talking about something like prolotherapy. But that's an old tool, from the 1950s, way older than I am, but I still use it in my practice. In the 1990s, we got into what's called PRP, and that stands for platelet-rich plasma. And what is the difference here? Well, platelets, as we talked about earlier, can be extracted out of your bloodstream, just like a lab draw, standard lab draw. We can remove the red cells, remove the white cells. We have the platelets left. The platelets have all these growth factors to stimulate healing more powerfully. And now, through the same injection process, the injection doesn't really change our technique of doing it, but we can stimulate this healing response, these growth factors to stimulate repair more powerfully than we can with prolotherapy. And that came to be in the 1990s. And I was doing a lot of that during my sports medicine fellowship in the late, not the late 1990s. It was really late 2000s, I guess, 2009, 2010. But at the same time, what was evolving was the ability to use stem cells, because now stem cells are an even more powerful cell in our body. So stem cells are held in reservoirs of the body within our bone marrow. We have some tissue banks that are not just energy storage, but within our fat or our adipose tissue, we have some stem cells there as well. And we have these fat pads around joints that are thought to not just simply cushion tendons from rubbing on the structures, but they're reservoirs of some of these stem cells. So we can take these out of a patient now, very simply in an office-based procedure through local anesthetics, and we can extract one's bone marrow. It's not a painful procedure, despite what some things say on the internet. If you're properly numbed up, it's not an uncomfortable thing to extract one's bone marrow. You can extract fat tissue, which is very easy, and we used a fraction of that as a grafting material, so that if there's larger tears, say around a tendon or ligament, we can fill in some of those tears, and then we can activate them with growth factors, because that's what we're getting from the platelets is really growth factors. And we're getting from stem cells is a more powerful healing cell. So now in the early 2000s, we saw a stem cell, correctly, we still think this, a stem cell can convert into a new cell. So if you have a damaged cell and your body is receiving those chemical signals, and it activates your bone marrow supply of stem cells to send them out into the circulation, your bloodstream, find the injury, find the damage, convert a new cell on site to repair a cell that was injured. Well, that was the primary mechanism by which we thought stem cells could do that. And they can do that so many times. They can stimulate a new cell, they can regenerate themselves, a new cell turnover, or they'll sit there dormant for a period of time, or eventually the cells will die. So our cells do get depleted out of our body and stem cells as we age. So the older we are, the less we have in our reservoirs, but we can still access those cells and we can still use those cells. And then in 2013, this was a Nobel Prize winning discovery that stem cells, inside the stem cell itself, it had these little packets of growth factors with little like blueprints for building cells. And these were called exosomes, or the name given to them was exosomes, because it would release these growth factors out of the stem cell. So not only would we get this conversion maybe of a cell turning into another cell, but we'd have this release of exosomes, which would have a one-to-many cell response. So now we could regenerate many cells in that area and surrounding areas, because these could expand because they're much smaller. They could expand into other areas around that targeted site where we're injecting them. So we're basically gaming the body's own ability to repair with these tools. We're running it through the same pathways that would normally utilize, but we're targeting it to the exact injury. So the body was kicking these cells out, and what happens over time with the age of the patient, the length of time that the injury's been there, the demand they keep putting on it, it keeps shifting this way, and it starts to slide down the hill. What we can do with these type of treatments is nudge things back the other way. But rather than waiting on the body's supply of these cells to get there, because what happens is if you have a knee joint that's arthritic, your body has been trying to release stem cells from those surrounding bones, your femur, your thigh bone, your shin bone, your tibia, and push cells out from underneath the cartilage or into the circulation that can go to your joint and help heal it. The problem is you burned out the supply, and most people have over many years. So we can restock the supply of workers that are trying to repair the damage there by taking your cells and putting them back into the body, but targeted at that site. And I wrote a whole consumer guide on this technology in 2019 and updated at the current state of like, where are we at with all this? What are the new advances? What do you need to look for in a practice if you're looking at these kind of treatments, such as we do in my office? But there's many practices out there that aren't doing these treatments at the highest level. They're not using the right technology. They're using very old technology, and that's not going to get people the greatest effect they want. So I would encourage you to read that guide, which I'll have in the resources for this section, because it's going to give you a real deep dive into this area, but written simply so you can read it in less than an hour. But it's going to bring you current on what we're doing in this area and everything else that's going on in the field of stem cells and regenerative medicine as it evolves. Because the last thing I want to touch on is there is this continual evolution. So the treatments I was doing in my practice 6 years ago, 7 years ago, 10 years ago, they're nothing, even a few years ago, they're nothing like what I'm doing today. And they're not going to be anything, like we're doing today 3 years from today. Meaning these are still going to get better and better and better as we understand this technology, we understand the deeper level inner workings of the body and what we can do. And maybe we get some of the regulatory red tape out of the way to get more of this stuff into the conventional pipeline of medicine, which we're already seeing some things moving that way. So it's very positive. But there's just ongoing discovery after discovery. So I'll call them the others. And this is, well, it's not the others that show Lost. They were the others, but the others are other things that we can be using. So these are growth factor and cellular products, we'll call them, that are made from other sources, so not from the patient. So I'll give you an example. There's a product in my office that I use that's called an exosome growth factor, and it's derived from umbilical cord stem cells. So during a live birth, if the family elects not to keep the umbilical cord, they can donate that, and companies will buy those from hospitals. Out of the umbilical cord, they can extract the blood, and out of the blood, they can extract the stem cells, and out of the stem cells, they can extract the exosomes, or they can attempt to keep the stem cells intact. And then there's other, you think about development, right? A rapid development and regeneration, or really generation. It's not regeneration at that point, but a baby generating over 9 months. The amniotic fluid, the placental tissue, all those things have healing cells and growth factors and properties. And all of those things by various companies are being utilized, manufactured in a way that it's safe, sterile, to inject in another patient without a complication. Because at that point, in that stage of life, most of those cells are what we call immune privileged, meaning they haven't been tagged. Like if you were to get somebody's blood now transfused into you that doesn't match you, your body would go to war with those other cells because it would look at it as foreign and harmful. But at that age of development, they haven't tagged all those cells yet, and this is why we can take some of those cells or growth factors, safely use them in other patients. So there's a whole set of things that I'm not going to get into in this video. That's a deeper level video for another day as to what we can use in that space. But the fact of the matter is, conventional medicine, when it comes to orthopedics, when it comes to pain management, when it comes to treatment of these orthopedic problems, whether it's joint pain, back pain, muscular tendon ligament injury, these are game-changing technologies that have been around for years and years and years. And they've gotten better and better and better. So if you're stuck in that middle space where you've tried the other treatments, you've reworked things as we have in the first few weeks of this course, then you owe it to yourself to look at these kind of treatments and see, do they fit for what you have going on? And I'm happy to jump on the phone and do a discovery call on your case to really figure out what's going on. I got to know the nature of the injury, things that have been done, the state of that, again, testing instead of guessing, look at some imaging, really figure out the state of that structure to see what the right treatment is and match it to it. But so many people are left in this middle space. Okay, they've been hurting for a long time, suffering for a long time, trying all these medications, all these other shots, all these things for a long time. And all the while, their quality of life is going downhill. It's literally sliding down the hill, eroding before their eyes, and they feel like there's nothing they can do about it. And many times they've seen somebody for an opinion on, say, a knee joint, and they say, well, Mrs. Jones, your knee's bad, but it's not really bad yet. So why don't you just wait until it's really, really bad, and then you come in and we'll replace it? Because that is the conventional treatment when it goes all the way down the hill. Well, we have these great technologies and surgeries now that have gotten better and better, and you can just replace it. But if you don't want a replacement, if you're in that middle space and you say, well, that's not appealing to me, then this is really what you should be looking at. In 2020, there is nothing more powerful that we can use to shift what's going on in one's body orthopedically than tapping into some of these treatments right here.